Deepa Chand from the University of Illinois College of Medicine, and in this module we will cover hypertension. Well, the first thing about blood pressure is that you have to take the blood pressure correctly. And here I think it's pretty obvious that we don't take blood pressures this way. So how do we take blood pressures? Well, what we want to do is have whoever we're taking a blood pressure in seated upright with an arm supported and outstretched on the table. You want the person to be in a quiet state and very comfortable, and you want them to be rested for about 3 to 5 minutes before taking the blood pressure. And this is irrespective of if the person is an adult or a child. It may be a little bit more challenging in an infant in terms of resting them and keeping things quiet, but certainly you can use the parent to help you and a pacifier, but ideally you want the person to be in a calm, rested state, and you want to support the arm with the feet flat on the floor and your back straight and supported. So in a nice, relaxed form. The general rule of thumb is to take 3 measurements and use the mean of the last 2. So now that we've covered how to take a blood pressure properly, who should you obtain a blood pressure in? In children, blood pressure should be measured annually at the age of 3 years and older in all children. And they should be checked at every health encounter. So every time they are seen by a healthcare professional, if they are obese, taking medications that are known to increase blood pressure, have a history of cardiac or renal disease, or if they have diabetes. Children under the age of 3 should have their blood pressure measured if there's a history of prematurity, specifically less than 32 weeks gestation, or if they were small for gestational age, had a very low birth weight, or if there was anything else that would signify prematurity in the patient, such as unknown prenatal care. If the patient had neonatal complications requiring intensive care unit stay, and specifically an umbilical artery line, they should have their blood pressure measured. If there is a history of congenital heart disease, either repaired or unrepaired. If there's a history of recurrent urinary tract infections, hematuria, proteinuria, or any other renal abnormalities, or any urologic abnormalities. If there's a family history of renal disease, the child should have their blood pressure measured. Certainly, if there's a history of organ or bone marrow transplant or any other oncologic process, a blood pressure should be obtained. If they're on any medications that are known to elevate blood pressures should be checked. And finally, anything else that would be a systemic illness that would be associated with hypertension. So in other words, if the patient has any chronic medical conditions of any form, it's probably a good idea to check their blood pressure, even if they are not 3 years of age. When you're measuring the blood pressure, you can use an oscillometric device as long as the device has been validated in children. There is a website that I've provided here for you that can give you a list of those devices that are approved specifically for use in children. The proper way to take a blood pressure is critical. There is a well-done video available from the American Academy of Pediatrics. I've provided you with the website here as well that can provide a good tutorial on how to measure blood pressures in children. In order to make the diagnosis of hypertension, blood pressure, abnormal blood pressures need to be confirmed on 3 separate occasions before that diagnosis can be made. I often get asked, what about home measurements, wrist devices, school nurses? If these are done properly, they can all be used in terms of obtaining blood pressures that you can use to make diagnosis and assess the patient properly, even after making the diagnosis of hypertension. This table is from the Task Force on High Blood Pressure in Children and Adolescents. And what I'd like to emphasize is that blood pressure is determined based on the person's age, gender, and height. And therefore, what you want to do is consult these tables to see what the upper limits of normal are with respect to blood pressure, and what degree of elevation there is in terms of that blood pressure reading, if it's either at the 90th percentile, the 95th percentile, or significantly higher. And the reason that becomes important is that's what we use to categorize and stage blood pressures. So a normal blood pressure would be a blood pressure reading at less than the 90th percentile in a child based on that age, gender, and height. Once a patient or a child, once a child is 13 years of age or older, adult values can be used, and the adult value to define a normal blood pressure is less than 120/80 millimeters of mercury. The definition of an elevated blood pressure is that blood pressure which lies between the 90th and 95th percentile, or is greater than 120/80 millimeters mercury to the 95th percentile, again for age, gender, and height, whichever is lower. Stage 1 hypertension is between the 95th percentile of blood pressure to between the to the 95th percentile plus 12 millimeters of mercury, or 130 to 139/80 to 89 millimeters mercury, whichever is lower. So as you see, we have this component of the norms based on the age, gender, and height, and then we max at the adult levels. And therefore, based on that algorithm and following that, stage 2 hypertension, which is the highest stage that we have in terms of categorization, is any blood pressure that's greater than the 95th percentile plus 12 millimeters mercury, or greater than 140/90 millimeters mercury, again, whichever one is lower. On the right side of the table, you will see that the values depicted there for any child aged 13 years or older, we use the adult values. To make this easier, here is a categorization and screening tool that is provided by the task force as well, which gives you kind of that upper limit of normal for the child based on their age in years, and this can be a shortcut sheet that can certainly be used. Based on the staging that you've just identified, you can fall into various categories with respect to the management of hypertension. And this table provides you that management in terms of screening, repeating blood pressures, etc., based on where they fall in terms of normotensive, elevated blood pressure, stage 1 or stage 2 hypertension. As you're thinking about the blood pressure elevation, you should also be thinking about what causes that elevation. And so in order to assess for that, you do want to look for identifiable causes of hypertension. And the way that we're going to do that is by doing certain tests. We start out, of course, with our history and our physical examination, and this could be very detailed. And what you want to do is use this history and physical examination to help focus your evaluation. And the target population really here is anybody with that elevated blood pressure greater than that 95th percentile. So you want to make sure that anybody who has hypertension, you're looking for an underlying etiology. And then you want to perform the diagnostic testing that can go along with that history and physical. Namely, at a minimum, you want to collect renal function parameters as well as a urinalysis to rule out any form of renal disease, both acute and chronic. You want to obtain a complete blood count to rule out any anemia or any other etiologies that could be consistent with causing hypertension. A renal ultrasound can be very useful because you can use that to detect renal scarring, any type of congenital renal abnormality, or any disparate renal size, which could indicate that there is a functional abnormality going on within the kidneys. You also want to evaluate for any comorbidities. You want to evaluate to see if there's a metabolic abnormality, such as hyperlipidemia or diabetes that might be at play here as well. You also want to consider if there are any exogenous drugs within the person's system that might cause hypertension. So a drug screen should also be considered. An echocardiogram can be very useful because it can help you identify potential etiologies, but it can also tell you if there is cardiac involvement as a sequelae of the hypertension. And so that's also a useful test. We generally do not do screening ECGs in children because the echocardiogram is much more sensitive and specific at detecting any target end organ damage that might have occurred. A retinal exam is also very important to do to look for any vascular changes that have occurred. Additional evaluation should be tailored based on your history and physical exam, as well as the results of those initial diagnostic tests. Here is a picture of the retina. And what you see in the top picture is you see a normal retina, and in the bottom, you see how the blood vessels are more engaged, significantly more prominent, and you see that engorgement, which is indicative of that retinopathy. When evaluating the patient, you also want to get a very detailed physical examination. You want to obtain vital signs, specifically looking at tachycardia, to see if there is evidence of hyperthyroidism, if any other factors could be at play, including any malignancies. As I mentioned, you're looking for retinal changes in the eyes as well. Your ear, nose, and throat exam should focus on adenotonsillar hypertrophy and a history of snoring, which could be indicative of sleep apnea. You want to obtain a good height and weight to evaluate for obesity, which can certainly play a role in the development of hypertension, whether it's primary obesity or secondary to another condition. You also want to look at the patient for any dysmorphisms that might be present, which could indicate an underlying congenital abnormality as well. Similarly, you want to evaluate your skin, their hematologic system, your cardiac exam, your abdominal exam, a genitourinary exam, as well as a good neurologic exam. In these tables, I've listed for you the classic findings as well as key things on history to evaluate for, with the correlating possible etiologies that one should consider when evaluating a child for hypertension. To summarize these tables, to kind of give you a little bit more of a concrete evaluation that should be done initially, the laboratories that should be obtained for all children with elevated blood pressures should include a urinalysis, a chemistry profile, which looks not only at the renal function, but also the liver function, a lipid profile, and a renal ultrasound as well. For obese children, a hemoglobin A1C should be obtained as a screening tool for diabetes. Again, an emphasis on that liver enzyme, on the liver enzymes, including ALT and AST. A fasting lipid panel should also be considered. The remainder of your diagnostics should be based on the history and physical examination, but could include a fasting serum glucose, a TSH-free T4, a drug screen, potentially a sleep study, and a complete blood count. As I mentioned, echocardiograph can be so helpful, especially in detecting end organ damage. Additional imaging studies could be warranted depending on the findings. And here I've just given you some examples of some things that you might find on these diagnostic tests. Here is a kidney ultrasound in which you see the darker gray sections, which represent cysts. So this represents a cystic kidney disorder of some sort. The etiology cannot be determined from the renal ultrasound other than to say that these are abnormal kidneys with cystic involvement and may be causing the hypertension that's occurring in the patient. Here is an angiogram that shows you in the circle there a blood vessel that does have stenosis. So this is renal artery stenosis that is detected on an angiogram and is the etiology of this patient's hypertension. I've mentioned the echocardiogram quite a bit, so let's look at one here. If you look at the picture on the left, you see a normal heart with the ventricles being seen very nicely with a nice thin wall. On the right side, what you see is a left ventricle that has a very thickened wall, and this represents left ventricular hypertrophy. And a way to think about this is the heart is just like any other skeletal muscle. And as you lift weights and as you increase resistance, your muscles bulk up. Well, that's what's happening here, where the blood pressure is serving as the resistance. So you have that vascular resistance, which forces the heart to work harder and to build more muscle mass. And so you see this left ventricular hypertrophy as a result. And this signifies end organ damage within the heart and should prompt the clinician to intervene and reduce that blood pressure, because like other skeletal muscles, this is also reversible. So if you decrease the resistance, so if you decrease the blood pressure against which the heart has to pump, this can also reverse. It can take months to reverse depending on the degree. So it's not something where you need to keep checking the echocardiogram every month, but we generally do repeat this on a regular basis, and even more frequently if there is significant hypertrophy present. Let's talk for a few minutes about ambulatory blood pressure monitoring. This can be a very useful diagnostic tool. And so what you have here is a blood pressure cuff. And the box itself is slightly larger than a cell phone, and that's attached to the blood pressure cuff. And this records the blood pressure periodically, about every 20 to 30 minutes throughout the day and throughout the night. And this is done for 24 hours. And this is then downloaded to a computer for analysis. And the ambulatory blood pressure monitoring maps the blood pressure. And what it does is it confirms hypertension if present through this continuous monitoring that occurs. And so it validates or disvalidates the blood pressure measurements that were seen in the office. This can be a very useful tool, especially in children and adolescents with high-risk conditions. And it really can give you a good picture of what the blood pressure is doing throughout the day, and can also give you some prognostic information in terms of risk for target organ damage. Another great situation in which this is very useful is when you suspect white coat hypertension, meaning that the blood pressures are elevated in the office but not on a regular basis. So ambulatory blood pressure monitoring can assist in making this diagnosis as well. And again, it's done for a 24-hour period, and then the results downloaded and assessed. Let's dive a little bit deeper into the causes of hypertension, because I do want to help you classify this given all the information that I've just provided, which really is a massive list of underlying etiologies. When you think of primary hypertension, as we typically do in adults, this is something that we should consider if the child is older, if they are overweight or obese, and if there is a family history of primary hypertension. Otherwise, think of it as being secondary. And when I think of this as being secondary, I really go through the systems in terms of what is the most likely organ system responsible for that hypertension. And in children, renal and renal vascular causes top the list. So that's really where you want to focus your evaluation initially and go through the different organ systems. After the kidneys, then you get into the heart, and you're looking for any type of abnormalities there, including coarctation, and your echocardiogram once again can be very useful. Then you go through endocrine causes, which can include the more common ones of catecholamine excess, congenital adrenal hyperplasia, depending on the age of the child, but more often in infancy, familial hyperaldosteronism, again, your family history can help you guide this, or hyperthyroidism. Medications remain a mainstay cause of hypertension, namely corticosteroids and certain over-the-counter medications. Then you start thinking of your other etiologies, which become less common. So this is kind of a systematic view that I often use in terms of thinking through the causes of hypertension. When you're talking about neonates, you want to have a high index of suspicion specifically for congenital renal disease, primary pulmonary disorders, cardiac disorders, and central nervous system disorders as well. Once you've ascertained that the patient has hypertension, what we want to do is treat that patient to bring the blood pressure down, irrespective of etiology. And the goal here is to reduce that blood pressure both systolically and diastolically to below that 90th percentile, and certainly below the 120/80 in adolescents greater than 13 years of age, or greater than or equal to 13 years of age. We want to prevent end organ damage. I've shown you the cardiac abnormalities that can ensue, and we want to prevent that dysfunction. We want to prevent the retinopathy, peripheral vascular disease, as well as chronic kidney disease. So how do we treat these patients? Well, the first step, irrespective of the stage of hypertension or the etiology, is that you want to induce a therapeutic lifestyle change. And this must be family-based in order for the child to be successful. If they're obese, you want to work on weight reduction. Studies have shown us the decrease in BMI of 10% can result in a blood pressure decrease of 8 to 12 millimeters mercury. This could make the difference between having to take medications, not having to take medication, avoiding end organ damage. Regular physical activity is encouraged, and likewise a decrease in sedentary activity is warranted. We recommend 40 minutes of moderate to vigorous aerobic physical activity at least 3 to 5 days per week. Stress should also be reduced whenever possible. Dietary modification should include a diet that's high in fruits and vegetables and low in sodium, as well as added sugars. This table here depicts for you how many servings per day are ideal in this setting, and we should aim to meet these. And again, it should be a family-based intervention. If you have access to a dietitian for the patient as well as the family, this can often be very helpful in terms of putting these servings into more of a tangible use. When needed, pharmacologic therapy should be initiated. We like to start with a single low-dose medication. And the patients who should receive therapy include those that remain hypertensive despite a trial of lifestyle modifications, those who have symptomatic hypertension, those who have stage 2 hypertension without a clearly modifiable factor, such as obesity, any stage of hypertension that's associated with chronic kidney disease or diabetes. So irrespective of the stage, those patients may warrant or should warrant pharmacologic therapy. We generally start with an angiotensin converting enzyme inhibitor. You can alternatively use an angiotensin receptor blocker, a long-acting calcium channel blocker, or thiazide diuretic. When we're talking about long-term therapy, irrespective of the class of medications you use, it's important to choose an agent, know the dosing, know the frequency, as well as the formulation. It's of course also very important to note any contraindications, as well as common adverse effects, so that you can educate the patient as well as the family to monitor for these. Some of these do require laboratory monitoring as well. There are certain medications that could be toxic to a fetus, therefore should be used with caution in adolescents who have the potential for pregnancy. Generally, what I like to do is take 1 or 2 agents within each class and know them well. That way I know the dosing well, I know the contraindications, the frequency, etc. So generally we like to do that. What I've provided here are the most common medications and their properties here. And so this slide goes over ACE inhibitors specifically. Here we go through angiotensin receptor blockers. And as you can see with both of them, pregnancy is contraindicated due to the risk of fetal toxicity. It's important, as I mentioned, to educate the patient about potential adverse effects, which sometimes are dose dependent and sometimes are not. Here I've provided you the dosing schema for thiazide diuretics. These can be especially useful for those who take in high sodium diets, because remember how thiazide works. It induces a natriuresis. So if you're somebody who's taking in too much salt, which can expand the intravascular space, which can worsen hypertension, a thiazide diuretic can help to decrease that sodium load by excreting it and in your blood pressure control. So this is a therapy that can be used for that specific purpose in those who have high sodium intakes. Calcium channel blockers can be used. I've depicted a few here. What's nice about calcium channel blockers, depending on the class, and here what's nice about calcium channel blockers as a class is that there are short-acting ones, there are also long-acting ones, there's extended release forms as well, thereby making the dosing a little bit easier as well. We have to spend a moment talking about beta-adrenergic blocking agents. These were used quite frequently. However, due to some limiting factors, we don't use them as widely anymore. Partially because they do differ widely based on the pharmacologic properties and potency. So they're not interchangeable, which makes them less usable. We cannot use them in diabetes as they can alter the serum glucose levels and can cause aberrancies there. Similarly, we do not use them in asthmatics. Beta blockers can impair athletic performance. The heart rate lowering can also be a limiting factor. So we don't use these as first or even second line medications, but they are still available and do have a role in certain conditions as well, but are reserved for third or fourth line agents. Similarly, vasodilators, which act on smooth muscle to reduce that vascular wall tension, can be used. These can be potent and can have significant side effects. So these are also reserved for quaternary use and are definitely not used as first, second, or even third line agents. If these are needed, this really should be done in conjunction with a specialist. Emergency therapy can be warranted, and this should be considered if the blood pressure is greater than 30 millimeters above that 95th percentile. And the reason is because cardiac failure, seizures, headaches, visual disturbances, and malignant renal changes may ensue. So you're trying to prevent that as quickly as possible. We're not trying to normalize their blood pressure at this point. We're trying to bring it down to about the 95th percentile. So you want to get them out of the danger zone in terms of those sequelae, but you want to do this nice and slowly. So your goal is 95th percentile, but what you want to do is reduce that blood pressure slowly. So you want to reduce it by about 25% over the first 8 hours, and then the remainder over the next 12 to 24 hours. So this should be a somewhat gradual decrease in blood pressure that should ensue as you treat these patients with emergency medications. Here is a table of the various emergency medications that can be used. Just like with chronic therapy, you want to know the class well, know one or two agents within that class, how it's dosed, the route of administration, as well as any side effects that the patient might experience, and these should be anticipated for. And whenever you're choosing an agent, kind of the rule of thumb is that you want to know the onset of action for the drug used. In an acute situation, you need to know, is this drug going to take effect immediately, within minutes, within hours, within days? Because you need to sometimes intervene a little bit quicker, and so that may impact what agent you use. Similarly, you want to know when will the effect wear off, because that's the time you have to determine what you're going to do next. If it's give another dose, if it's choose another agent, or if it's treating the underlying condition. And that's why it's so important to determine what the underlying cause of that hypertension is, so you can tailor the therapy to ultimately treat that underlying cause. You want to anticipate if you're going to need to use this long term. And if you are, what's easiest to convert if you're using an IV form to an oral form, if it's possible. Sometimes it's not, because you have to do what you have to do in an urgent situation. But throughout the urgent course, you should be anticipating the dosage adjustment as well as initiation of long-term needs. One question we get asked quite a bit is, what about sports? We don't want them to lead a sedentary lifestyle. However, we don't want to put them at risk either for worsening the hypertension. So according to the task force, the current recommendation is that children with stage 2 hypertension should be restricted from high static sports in the absence of end organ damage, including LVH or concomitant heart disease, until the blood pressure is in the normal range after lifestyle modification and or drug therapy. So in other words, stage 2 hypertension should be restricted until you reverse any end organ damage that can happen and their blood pressure is back in the normal range. However, if the elevation in blood pressure is below that stage 2, they may participate in sports once you've evaluated and determined that there are no end organ effects and that the risk of that sport would be minimal with respect to that target organ. So again, if they're elevated and you don't see that end organ damage, you can allow them to participate. If you do see that end organ damage, then you want to correct that, and you want to get their blood pressures in a managed state, and then you can reassess and include them for sports participation. So given all of that, let's go to some board style questions to determine if we've learned something new today. So a patient is referred by the pediatrician at 3 years of age because of 3 consecutive blood pressure readings between 150 and 160 millimeters mercury over 100 to 106 millimeters mercury diastolic. The patient has numerous cafe au lait spots on exam. What is the most likely cause of his hypertension? A, coarctation of the aorta. B, renal artery stenosis. C, polycystic kidney disease of the autosomal dominant type. D, renal dysplasia. Or E, urinary tract infection. The correct answer is B, renal artery stenosis. And this is a little bit of a tricky question because it's a double association type question. You first need to know that the diagnosis, as depicted by the cafe au lait lesions the patient has, is neurofibromatosis. And then you need to extrapolate that to know what the renal pathology associated with that is, and that's the renal artery stenosis. The other condition that can occur as part of the neurofibromatosis is pheochromocytomas. Pheochromocytomas are less common than renal artery stenosis in these patients, and certainly was not an option choice in this test question. So renal artery stenosis is the correct answer here. I hope that today I put together the complexities of blood pressure measurement, evaluation, diagnostics, as well as therapies for hypertension in one package for you today. And what I will leave you with is that you need to make sure, first and foremost, that you're taking the blood pressure correctly and then intervening as appropriate. And with that, this concludes this segment on hypertension, and I wish you the best of luck on your boards.